Okay, hi everyone. I think we're going to get started. For those of you who I haven't had a chance to meet yet, I'm Val Montessori. I'm the head of infectious disease here at St. Paul's, and it's my pleasure to be here today to introduce Grand Rounds. Before we start, though, I just want to take a moment to acknowledge with gratitude that we are on the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Squamish, the Tsleil-Waututh, and the Musqueam nations, and ask that those not on these lands, and we want to think about where we are and reflect on the privilege that we have to be here today. Now, Dr. Dinh is one of my colleagues. I've had the pleasure of working with her for many years in infectious diseases, and today she's going to talk to us about bacteremia, focusing on the following objectives. She's going to review the epidemiology, pathogenesis, and diagnosis of bacteremia, analyze common causes of bacteremia, and then highlight recent studies on bacteremia. So with that, I will give the floor to Dr. Dinh.
Thanks, Dr. Montessori. Thank you, everyone, for attending and spending your noon hour with me today. So as part of just some reflection about our role in reconciliation, I just want to remind folks about the calls to action from the Truth and Reconciliation Commission, which includes establishing measurable goals to identify and close gaps in health outcomes between Aboriginal and non-Aboriginal communities. So I think to start with that, we need to have data, and there's actually not that much data that's local to Canada. One study in the north that looked at invasive bacterial disease did find quite a disparity in terms of rates of invasive pneumococcal, group A strep, and H influenza infection, comparing Aboriginal to non-Aboriginal populations. I have no disclosures. So Dr. Montessori already mentioned my objectives, so we'll just get right into it. So I'm on ID consults this week. Just thought I'd give you kind of a flavor of what's been happening. I've been called about a patient with micrococcus in blood, strep parasanguinus in blood, MRSA, Pseudomonas, strep pneumo. Not all the same person, obviously. So this is one of the cases. As an example, is an 85-year-old male with dementia who presents with hypertensive emergency and acute MI. Is initially afebrile with a slightly elevated white count, and we're asked to see this patient for Vierdens group strep in the blood. So some of the questions that come up in my mind immediately would be, how were the blood cultures collected? So one set of blood cultures was collected, antibiotics were started before repeat blood cultures, which is also one set. So we kind of face some clinical management conundrums, which I'll get into further. So taking a step back, we can think about the classification of positive blood cultures. And so we can have either bacteremia or contamination. So under bacteremia, these classifications are not consensus, so different resources will kind of describe these a bit differently. But you can think about primary bacteremia as being related to direct inoculation, a possible unidentified source, or bacterial translocation. Whereas the secondary bacteremia is probably what we see maybe the most often, which is related to spread of infection from another site into the bloodstream, kind of spillover. Another important category would be intravascular, or sometimes referred to as endovascular infection, including endocarditis, infection of grafts or cardiac devices. And lastly, associated with an intravascular device such as catheter-related bloodstream infection. So we fear bacteremia because of complications including death, right, and including sepsis. It was interesting to note that in a large cohort, blood cultures are positive in only about 1/3 of patients who present with septic shock. And in fact, up to 1/3 of those cases are culture negative from all sites. So there is some overlap, but maybe not as big as you might have pictured. In terms of the epidemiology of bacteremia, There's a big study called the Global Burden of Disease, which looks at global incidence and outcomes of important conditions. And as it pertains to bacteremia, there are about 600,000 cases and 90,000 deaths annually in North America. And globally, there are 2.9 million annual deaths. And as an infectious etiology, it's the second cause to respiratory tract infections. In the high income setting, in fact, Staph aureus bacteremia is the most important cause of bacteremia, with 300,000 deaths annually, and in the high income context, accounting for about a quarter of bacteremia related deaths. Systematic review and meta-analysis looked at the mortality of Staph aureus bacteremia and estimated it to be about 27% at 3 months. So how do we go about diagnosing bacteremia? So you need to suspect it, you order some blood cultures, and you interpret the result, right? There are some, I'll bring your attention to a few other steps, which include blood culture collection, blood culture workup, and blood culture reporting, which I think as patient-facing clinicians is sometimes a little bit of an obscure black box. So when to test for bacteremia? So, if your patient's sick, right? Severe sepsis and septic shock, if you suspect endovascular infection specifically. But beyond those first 2 points, we should be considering what the pretest probability is based on the syndrome that your patient has. In addition, we can consider what is the yield of or access to the primary source cultures, which I'll talk a bit more in the next slide. And, we kind of have the dogma of collect your blood cultures prior to starting antibiotics. But how important is that? So Chang and authors did a nice little study where they looked at septic patients presenting to ER, and they collected paired blood cultures before and after antimicrobial initiation, and found that the post-antimicrobial blood cultures were only about 50% sensitive. So this chart, the bottom of the slides are cut off. This chart is reproduced from a study by Faber and colleagues in 2010. They did a scoping review of different infectious syndromes and the incidence of bacteremia associated with them, and classified them into kind of high, intermediate, and low probability categories. So it's pretty intuitive that in patients with perhaps intermediate and high pretest probability of bacteremia, that blood cultures are indicated. However, they went on to discuss yield of bacteremia as it pertains to yield of cultures as it pertains to blood versus the primary site. And studies have demonstrated that, for example, hi, Taylor, could you mute yourself, please? Sorry to put you on the spot. In infections such as discitis, native vertebral osteomyelitis, or epidural abscess, data supports that the blood culture yield is actually higher than the yield from the primary site. Probably that can be in part explained by the fact that, there's going to be probably delays in obtaining that specimen, and you will have started antimicrobials in the meantime. But just to say that blood cultures have a dual role in that situation. On the other hand, an infection such as acute pyelonephritis, the yield of a urine culture is actually higher than the yield of a blood culture. That being said, perhaps you are encountering a patient who cannot provide a urine culture for whatever reason, in which case that highlights the potential role for a blood culture. So blood culture collection, there's kind of many steps involved here, but a blood culture set consists of 2 bottles. One is incubated under aerobic conditions and one is anaerobic. A typical request or order is for 2 sets of blood cultures. These are taken from 2 separate sites, which helps to interpret possible skin contamination, which we'll discuss kind of in detail later. Other important components would be skin antisepsis to reduce the rate of contamination, how the blood cultures are collected. So generally speaking, we are wanting a peripheral draw for blood cultures, except in the scenario where you're specifically concerned about a catheter-related infection. And then ensuring that an adequate blood volume is collected is also important in order to optimize the yield of the blood culture. Following this, the blood culture bottles are shipped down to the lab and then incubated in continuously monitored blood culture systems. So it's kind of a big machine. All the blood culture bottles are slotted in. They're incubated around 37 degrees Celsius. And the machines have automated detection of the production of metabolic products, primarily carbon dioxide. When it reaches a certain threshold, an alarm goes off, the tech comes and retrieves those specific bottles and then does a direct gram stain aspirated from the bottle. Okay, so up in the top right corner, you can see a gram stain of kind of gram-negative cocci there. So subsequent to that, so that's kind of that initial information that you get reported out, you know, 2 sets of blood cultures, gram-positive cocci and clusters, or what have you. Following this, the sample is set up to try to isolate it in pure growth. So they inoculate plates, such as the blood agar plate seen in the bottom right-hand corner, and incubate it for 24 hours before kind of next steps tend to occur. So the purpose of pure isolation is for further testing, which includes identification and antimicrobial susceptibility. So identification involves conventional testing, which is biochemical tests that, you know, that can take kind of more than a day kind of turnaround time, as compared to some newer technologies, which are can have a very helpful role, such as molecular testing. So for example, checking for the MEK-A gene for Staph aureus isolates, which would be consistent with an MRSA that helps you with your therapy, and MALDI-TOF, which uses mass spectrometry to identify bacteria and other pathogens. And then back to blood culture reporting. So which antibiotics are reported really depends on or is drawn from an international lab standard. In North America, we use the Clinical and Laboratory Standards Institute, or CLSI, and then there's a European similar institution. So how they decide on what antibiotics to report, it depends on in vitro and in vivo evidence from kind of a drug specimen pair. So I'll just bring your attention to the susceptibility table that I've kind of mocked up in the bottom left corner. What I'm showing you is that this person has MRSA everywhere, but specifically we have the first column is blood, the second column is from a tissue biopsy, and the third column is urine. And what I want you to notice is that some antibiotics are only tested in one category, right? So for example, a very classic example would be nitrofurantoin in urine. You would only report that out in urine because it's appropriate for kind of a uncomplicated cystitis, but doesn't provide enough levels in the blood to treat a bacteremia, okay? So these choices are based on these standards that are required for lab accreditation. Secondary to the susceptibility reporting, there can be lab or institutional specific commentary. So for example, if you see a Staph aureus blood culture positive in your patient at Providence Healthcare, you'll get this comment to refer to the treatment guidelines. I think VCH has a different comment, like maybe a bit more specific about consult ID. There's kind of, you know, some discretion there. All that to say is there is kind of a physician experts behind the scenes that are making or orchestrating everything there. So back to us, so interpretation of the blood cultures. So I'll present a couple of simple cases, or I mean, distilled cases. There's not a lot of detail. So suppose you're seeing a 65-year-old female with type 2 diabetes who's admitted with dyspnea and is diagnosed with community-acquired pneumonia. You start her on standard treatment of ceftriaxone and azithromycin, and by post-admission day 2, she starts to improve, but on post-admission day 2, you're notified that a blood culture is positive for gram-positive cocci in clusters. So you find out that it's 1 out of the 4 bottles that has turned positive. So how would this affect how you assess the patient, what investigations you might do, and what treatment you might choose? So we'll get back to discussing this, what we would do. On the other hand, another case to contrast is a 75-year-old male with diabetes, recurrent UTI, and a TAVI. This patient is admitted feeling generally unwell with a leukocytosis and has a provisional diagnosis of urosepsis. He is also improving on ceftriaxone. However, on post-admission day 1, you are called that blood cultures are positive for gram-positive cocci in clusters in 4 out of 4 bottles. So how does this case differ from the first one in terms of assessment, investigations, and treatment? So, when we see gram-positive cocci in clusters, there's a concern that this could be Staph aureus bacteremia, which, as we've highlighted, is a serious condition requiring acute management. However, there are other considerations. It could be a coagulase negative staph, which we'll label cons. It could be micrococcus. And then in this context, it could either be a true bacteremia versus a contaminant. So you kind of have a decision point regarding treatment. Should you add vancomycin? And in the right bottom corner there is a gram stain of gram-positive cocci in clusters. So how do we determine whether or not this is bacteremia? So we can kind of go through a checklist. Firstly, does the patient clinically present with a syndrome consistent with bacteremia? And if so, is that bacteremia likely to be gram-positive cocci? You can think about how many bottles were positive. There's a big difference between 1 bottle versus 4 bottles in terms of our suspicion for a true bacteremia. Were the blood cultures drawn peripherally or through a central line? How long did it take to grow? Where things that maybe take more than 24 hours to grow start to be more likely to be a contaminant, with some caveats. And then, are there specific risk factors for coagulase negative staph bacteremia, such as hardware? So going back to that first case, so we've got our patient with CAP who's improving on standard therapy. We've got 1 out of 4 blood cultures positive. So in this case, I would say that I suspect a contaminant. You can consider no repeat blood cultures and no additional antibiotics with monitoring. What about, suppose instead that she had a TAVI in situ, okay? So in this case, she's still better, right? So we still take the whole patient, she's improved. I would repeat the blood cultures in this case to make sure that there is no sustained bacteremia, but consider providing no additional antibiotics and just monitoring the patient. To our second case, we had that 75-year-old male with query urosepsis and a TAVI growing 4 out of 4 blood cultures with gram-positive cocci in clusters. So I would say based on the speed of growth and the number of bottles that this is likely to be a bacteremia. And I would cover this person for possible MRSA and consider to repeat blood cultures either today or the 3rd day and investigate for TAVI infection. In this patient, it turns out to be a methicillin susceptible staph epi. Okay, so there's a couple of caveats or points I want to make about this. This perhaps explains why the patient was getting better on ceftriaxone, but additionally, even though it's staph epi, 4 out of 4 bottles, we should not consider it to be a contaminant. So speaking of repeating blood cultures, the general recommendation is to repeat not daily, but every 2 to 3 days. In who or what scenarios should we repeat the blood cultures? It can be based on the pathogen, for example, Staph aureus, Staph lugdunensis, which is a coagulase negative staph that can be virulent, similar to Staph aureus, any Candida species in blood, or any multi-drug resistant gram-negative bacteria. In the setting of endovascular infection, you'll want to repeat blood cultures to document clearance. If your patient is just not responding, perhaps has an undrained source or somewhere where there might be poor penetration of antibiotics. Those would be other considerations. So just to close out the contaminant part, here's a list of common blood culture contaminants there. On the other hand, these are clinically significant isolates, which essentially anytime you see in blood, you should look for a source and treat. Okay, so moving on to another case. So this is a 59-year-old male who injects drugs, who's admitted with an acutely inflamed left knee. This person has synovial aspirate and blood cultures, which all grow Staph aureus. So what is a workup of Staph aureus bacteremia? So generally, we want to really go back to basics and look for a source and look for seeding. So where did the pathogen come from and where has it gone? And we can't underestimate the importance of good history and physical, as well as serial physical history and physical to detect metastatic infection. So we're looking for a source in the skin, urine, lungs, abdomen, mouth. We think about predisposing factors such as any skin conditions like dermatitis, injection drug use, any lines or prosthetic material in place. Sometimes the pattern of bacteremia can provide a clue as to what is going on with the patient. So for example, if you saw continuous bacteremia, you might be more suspicious of an intravascular infection. Whereas if you had intermittent bacteremia, for example, with negative blood cultures between positive cultures, this might be more representative of a secondary bacteremia. So much as you do a history and physical for source, you do it for seeding. So you look for where it could go, including bone and joint, the heart, or any deep tissue abscesses. And then considering the pathogen is Staph aureus, if it is another organism that has a high propensity for endocarditis, you would do an echocardiogram. Sorry, my phone's just ringing a whole bunch. So as part of your assessment and workup for Staph aureus bacteremia, we recommend an infectious diseases consult. And at our institution, it's kind of an auto consult. And what's the rationale behind that? So the data date back to, I guess, more than 25 years ago now, with a 1998 study that looked at adherence to ID recommendations as a predictor of outcomes in Staph aureus bacteremia. So in those who where there was adherence to the recommendations, there was a higher cure rate. And this was in spite of the fact that those patients had higher metastatic infectious foci. So that was a pretty provocative kind of finding, and lots of people did subsequent studies, which were kind of summated in a systematic review and meta-analysis, which did still find consistent benefit. So they overall calculated a 30-day mortality that was 12% versus 26%. There were also improvements in 90-day mortality, relapse risk, and the appropriateness of antimicrobial and investigations. And to paraphrase our friendly Woody from Toy Story, you've got a friend in our local ID consultant, so don't be afraid to call. All right. So moving kind of towards treatment. So treatment is evolving, which is kind of going to comprise the last half of my presentation. So not to date myself, but sure, when I was training, bacteremia was historically treated for 2 weeks, pretty much all the time, at least, okay? And then the duration would be prolonged as determined by any foci of infection that requires it, such as bone and joint, endocarditis, or an undrained source. There are also some pathogen-specific factors. Again, it's Staph aureus. I mean, I think I've driven the point home that Staph aureus bacteremia is kind of different and serious, right? So Staph aureus bacteremia treatment is primarily intravenous, especially in the first 2 weeks. And I think by far and large, still for the whole course for most people. We'll talk a bit more about that. However, for pathogens that are not Staph aureus, we can certainly switch to oral antibiotics if possible, according to like drug susceptibility, appropriateness, and other patient factors. A question that sometimes comes up is related to the role of double coverage for patients with suspected or confirmed bacteremia. So we can conceptualize this as either double coverage in the empiric setting or for directed treatment, where empiric treatment is the use of 2 antibiotics to increase the chance that there's an active agent against a suspected or confirmed pathogen. Because we know that in sepsis, getting it right up front has a mortality benefit. Whereas directed double coverage would be the idea of using 2 active antibiotics from different classes once you know kind of what infection you are dealing with. So going back to the history of this, it was interesting to find that previously it was pretty routine for gram-negative sepsis to be treated with 2 antibiotics. However, this is an area that has been extensively studied, and cumulative data did not find any benefit to combination therapy and increase the risk of adverse effects. That being said, there is a role for empiric double coverage in certain scenarios. So for instance, if you are suspecting infection with Pseudomonas aeruginosa or resistant Enterobacterales, and highlighting particularly carbapenemase producing or carbapenem resistant, that might be a scenario where you would consider double coverage. However, you should also consider the patients and the institutional antibiogram. So if you have a high resistance rate for certain antibiotics, then you might consider double coverage as well. Consider also their prior antimicrobial coverage and on history, whether they've had healthcare exposure in general, but in particular in a high prevalence setting, such as seeking healthcare overseas. All that being said, we have to contextualize this in how sick the patient is. If you've got a patient with a simple cystitis, with multi-drug resistant, Pseudomonas aeruginosa, you're not necessarily going to be exposing them to potentially highly toxic antibiotics, and you could have time to wait for the culture versus your septic patient. So those would be kind of some scenarios where we would use double coverage upfront. However, once we have the identification of the pathogen and susceptibility, the recommendation really remains to continue to go towards monotherapy of a narrower spectrum when possible. This is the logo of the First Line app, which used to be called Spectrum, that incorporates local antibiogram data and allows you to search by syndrome, pathogen, and is extremely useful. So now we'll move on to duration. So how long should bacteremia be treated? Suppose we have a 45-year-old female with diabetes who has E. coli, pyelonephritis, and bacteremia. She initially presented septic and is improving on ceftriaxone, has had 4 days. So how would you treat this patient? Option 1 is to switch to Cipro, but give 7 more days. Option 2 is switch to some active oral agent, give 3 more days for a total of 7. Third option is switch to some other active oral agent and give 10 more days for a total of 14. So I'll take this opportunity to highlight a large trial on treatment duration for bacteremia called BALANCE, and acknowledge multiple Lower Mainland site and investigators. This study looked at hospitalized adults with bacteremia in 7 high-income countries. The intervention was 7 days of antimicrobial treatment versus 14 days, and the outcome was 90-day mortality. The study design was non-inferiority with a non-inferiority margin of 4%. Some important exclusions below, so we're not talking about Staph aureus here, significant immunosuppression, or again, patients who require longer duration by definition of their syndrome. So, I mean, not to bury the lead, the authors concluded that 7 days was non-inferior to 14 days. I do want to tell you a little bit more about the patients that were in the study so that you can think about the external validity of what they have found. So they enrolled, about a third of the patients that were found to be eligible. And looking into the reasons, the main reason that patients were not enrolled was because the clinician declined. Okay, so there is a possible bias to the population that was enrolled there. The majority of patients were presenting with a community-acquired infection, and there was excellent representation of patients who had admitted to ICU. The most common source of infection is urinary tract infection, which was significantly more common than intra-abdominal or hepatobiliary, lung, and then other sources. And the most common bacteremia was a monomicrobial gram-negative bacteremia, which is, kind of follows from the urinary tract presentation, with E. coli by far and away being the most common specific isolate, and second, Kleb pneumo, and third were Enterococcus species. So that being said, I think that this is, a very important study, and it's going to have a big impact on how we care for our patients. The strengths include, good representation from critically ill patients. I will add the caveat that the mortality rate in the study was about 10%. And, studies of bacteremia that have looked at mortality would estimate it to be anywhere from 10 to 30%, so perhaps on the low end. In terms of pathogens, I think that, stemming from studies about UTI pyelonephritis, people were already shortening the duration of treatments for some gram-negative bacteremia, but a strength of the study is to include, most pathogens, not Staph aureus, so we can potentially apply this treatment, the shortened treatment, to the gram-positives and non-Enterobacteriaceae gram-negatives. Along those same lines, this is a big study that allows us to shorten treatment of duration beyond the UTI syndrome, which I alluded to earlier. And also, again, with UTIs, we were comfortable using 5 to 7 days of Cipro if it was susceptible for pyelonephritis with bacteremia. But now, and we had limited data or data that suggested other antibiotic classes could not be shortened in the same way. But now we have a good study that had lots of use of beta-lactams and other antibiotic classes that supports a shortened duration. So I'll offer a reframing of how we think about uncomplicated secondary bacteremia. So I'd say that the old principle was secondary bacteremia defines or extends a duration of treatment up to 14 days. But I think we're shifting towards an idea where the treatment of secondary bacteremia could be the treatment of the primary infection, essentially. So I said, not Staph aureus, not Staph aureus. So how about Staph aureus? Okay, so Staph aureus bacteremia treatment. The risk of metastatic infection is high. And generally speaking, we approach Staph aureus bacteremia treatment based on whether the syndrome is complicated or uncomplicated, where uncomplicated is treated for about 2 weeks and complicated is treated for 4, 6, 8, 12 weeks. And IV treatment remains common and generally standard. However, just as there have been trials of endocarditis and bone and joint infection looking at oral antibiotic switch, the IV dogma in Staph aureus bacteremia is also being re-examined. So tell you about a study that looks at whether IV antibiotic duration can be shortened in Staph aureus bacteremia. This is called the SABATO trial, which is a very nice acronym for Staph aureus bacteremia antibiotic treatment options. It is a study of adults with low-risk Staph aureus bacteremia. We'll discuss that subsequently. And the intervention group received IV antibiotics for the first 5 to 7 days, and then were switched to oral antibiotics to complete their 14-day course. And the control group was IV antibiotics for the whole treatment course. The primary outcome was a composite of 90-day Staph aureus bacteremia complications. The design was non-inferiority, and again, to give you the author's conclusion, they did conclude non-inferiority. For interest, the oral antibiotics that were used in the study included Septra, clindamycin, or linezolid. So low-risk Staph aureus bacteremia. So I was just talking to you about complicated versus uncomplicated Staph aureus bacteremia. What does low risk mean? My interpretation is that low risk is kind of a surrogate for uncomplicated, but they didn't want to use that term because uncomplicated has a more specific definition. So drawing your attention to the Infectious Diseases Society of America guidelines on management of MRSA infection. These bullet points in the large font are the requirements to define something as an uncomplicated bacteremia, where we exclude endocarditis, there are no implanted prostheses, negative follow-up blood cultures within 2 to 4 days of the initial positive, defervescence within 3 days of starting therapy, and no sites of metastatic infection. So you can see that below, I just put that text in just to give you an idea of how difficult it was for them to define their population in this study in order to approximate what uncomplicated Staph aureus bacteremia looks like. Okay. So what happened? So this trial went on for 6 years, and they recruited about 4% of patients in 31 sites. Really like a Herculean effort in my mind. The study was halted halfway, and the sample size was halved due to slow recruitment. And due to that, they had to do the math and increase their non-inferiority margin from 5% to 10%. So you can think about, the acceptability in your mind of like 10% rate of Staph aureus bacteremia complications. The study primarily enrolled patients with methicillin susceptible Staph aureus, so not necessarily examining the MRSA population. And the majority of patients had venous catheter related bacteremia, specifically mostly peripheral IV associated bacteremia rather than central lines, which were a smaller component. So although the primary outcome was composite, just looking at the mortality, both all-cause and attributable to Staph aureus bacteremia, the rate of mortality was higher within the oral switch group, not powered for statistical testing. And furthermore, serious adverse events were higher in the oral switch group. So undoubtedly, this is an important study question that the authors diligently tried to answer. However, the design likely posed some challenges. What we know about uncomplicated Staph aureus bacteremia is that as a proportion of Staph aureus bacteremia, it's becoming less common over time. The patients we're seeing seem to be sicker, more sites of seeding, needing longer courses of antibiotic. To study uncomplicated Staph aureus bacteremia is tricky because you might inadvertently misclassify patients. You might enroll patients who look initially like they have uncomplicated bacteremia, but then throughout the course of their treatment develop complications. Stemming, authors have been keen to try to answer this question better, and multiple studies are underway, but I'll highlight a large study called SNAP, which includes kind of uncomplicated and complicated Staph aureus bacteremia. Another possible reason why the study didn't quite show us the results that we were hoping for could have been related to the intervention not being optimized. So I didn't get too much into the dosing of the drugs, but the dose of Septra that was used in this trial would be considered to be quite low. if you are curious, 1 double strength BID. So my bottom line is that if you are considering this, it might only be appropriate for very highly selected patients that require careful assessment for complicated bacteremia. I would focus more on MSSA patients and patients with peripheral IB-related bacteremia. So, in conclusion, to summarize what we've discussed today, blood cultures are an important workup of sepsis, endovascular infection, and in moderate to high pretest probability infections. We order 2 sets, ideally prior to antibiotics and ideally peripheral draw. The processing of blood cultures is a technically complex sequence, and lab physician oversight is essential. Blood culture contaminants are costly, so interpret carefully. Certain isolates are never considered contaminants. Staph aureus bacteremia is unique for its high mortality and propensity for metastatic infection. And in uncomplicated bacteremia other than Staph aureus, shorter treatment is better. And that's it. And there's my dog meeting her doppelganger. Thanks. Any questions? Comments? Dr. Casson?
Well, thank you for the presentation and the overview. It's always amazed me how we say 5 to 7 days. Most times we're not, that people hear it for the first time and wonder, well, should I have 7 days better than 5 days? And we talk about shorter duration. We've been using oral antibiotics for a long time, and there was a program presented by Dr. Kessler a few years ago who was advocating the treatment of endocarditis with oral antibiotics. We haven't moved that needle very far. So in looking at the data today, and you pointed out that the participation in some of these studies, the patient population was maybe not as representative of the study. So how do we interpret all of this on one final question is, or one final observation is, if we had 2 infectious disease people see the same patient, the recommendations might differ entirely in choice of antibiotics and duration, even if they're rival. So I know that's a lot, and I'm not trying to be pejorative, but maybe you could just comment on something.
Thank you. So I would say, with the 5 to 7 days comment, firstly, I would say that those increments are completely arbitrary, and we just pick numbers that, as humans make sense to us. 1 week, 2 weeks, 5, because we live in a decimal world, that sort of thing. So we don't know if 6 days is better than 7 days or what have you. So I think that while we still don't have great biomarkers that can reliably predict that the infection is resolved, for example, there's a lot of subjectivity in terms of the assessment of the clinical improvement/resolution of the infection to help us kind of really pin down when antibiotics can stop. So yeah, I think, in terms of does that confuse patients? Probably. It confuses physicians too. Yeah. So I think, it's very intuitive that we want things to be black and white, but I'm not sure that I can provide that black and white for that specific piece. As to variability in, IV versus oral use, I think that there's the evidence, but the everyday effectiveness of switching to oral, especially depending on the population that you encounter, remains to be fully defined. We certainly have a bias, I think, in our institution to have high levels of concern for, adherence and whatnot, which, might slow down some clinicians' propensity to switch to oral treatment sooner. I agree with you that it can be disconcerting, especially when we switch who's coming on to service, so that remains a challenging question. We do have kind of retrospective observational data in the injection drug use population, suggesting that in people who were switched to oral therapy because they were unable to stay in hospital, that in many cases the outcomes were still fairly good. Unfortunately, I would say, just to kind of add an equity piece, injection drug users remain highly marginalized in terms of inclusion into clinical trials. So although we think like biomedically they should respond in the same way that other people do, some real life data about how they do on an oral switch program that reflects the resources that we actually have to support would be welcome, I think.
I'll just make one other comment. In the New York Times magazine about 6 years ago, one of the university professors from Yale went to the emergency room and was given advice for a respiratory tract infection about this concept of 5 to 10 days is what they use. And he did a calculation and he concluded the reason we've chosen that is because of the decimal system. And it had nothing to do with antibiotics or medicine or bacteria.
Yeah.
It's just, and he actually, anyway, it was a really interesting discussion about how we think that had nothing to do with medicine.
And I think that ID clinicians, just as much as anyone else, are very firmly stuck on these like 5, 7, 10 numbers too. Yeah. Any questions from online or comments?
Hello, Queenie, it's Gary Chan here. This is like a very simple question. I was just wondering, how do we figure out when the timing to positivity is uncertain? Like, I know sometimes with flags, and I have to just calculate the time it is drawn to when it's resulted. Is there any other way to do it?
There's not. So Dr. Chan is referencing time to positivity as to interpreting kind of, I don't want to put more words in your mouth, but in particular, when we're considering line infections, comparing time to positivity in kind of central versus peripheral cultures. Yeah, it's well-defined in research studies, but in clinical practice, like part of the thing is that I think it varies by hospital, but for example, these blood culture systems are, incubate continuously, but there might not be a tech in overnight who actually pulls the bottle out at 2 a.m. to do the gram stain and does the reporting at that time. So the data that we get are inherently biased probably towards longer. And yeah, you can only calculate it based on collection time versus reported time, really.
Thank you.
Maybe one further question. There's always the issue of how many blood cultures should be used in the concept of blood cultures and how they're colored. Maybe you could address that.
So I don't think that, different guidelines say different things. I haven't done a deep dive on that specific area, but for example, I think one of the endocarditis guidelines is endorsing 3 sets. Every time for, like, say you had a patient who finished their endocarditis treatment, is well, but they're at risk for future endocarditis. If they ever have a fever, they endorse 3 sets of blood cultures, which is like aggressive, right? So 3 pokes, like 60 mils of blood potentially. It's not insignificant. I don't think that the 1 hour apart, I don't know, I would consult my colleagues in the room to see if there's any specific evidence for that. I don't know.
I don't know how much evidence there is, but certainly those of us who've been in practice for a while, which is the usual thing, heuristic thinking in medicine, but we are more interested in more sustained bacteremia. And by that, I mean, even 30 minutes apart, some of us would consider a sustained bacteremia. So if you do happen to be in a situation where you can ask for blood cultures to be drawn 30 to 60 minutes apart, it is of clinical interest to us if they still are positive in both those sets. Yeah.
And the phlebotomists actually have rules in terms of when they take the 2 sets. They're just not often followed because, you know, logistics, like if you're already at the patient's bedside, you don't want to come back, so often they're 5 minutes apart, but there are actually guidelines that the phlebotomists have.
Yeah. Do you have time for one more question?
Absolutely.
Okay, I'm curious about how people are thinking and behaving now when they are doing assessments for metastatic sites of infections in Staph aureus bacteremia. And the specific thing I'm asking about is that I have seen more interest in getting PET scans. And I don't know, yes, PET scans, yeah. I don't know if that's something that, I haven't had a chance to really look at that myself. I don't know if that's really becoming standard of care. I don't know if that's gonna change how I treat patients. And I'm just curious if you've come across anything about that.
I think I scanned something about PET scans, use a routine use of PET scans identifying more foci, but I don't think I have the reference at my fingertips for you. For me, I kind of think about it in the few cases where we've ordered one are really those patients who are having this relapsing or recurrent MRSA bacteremia course, you know, in spite of already receiving 6, 8, 12 weeks of antibiotics, more to make sure that we haven't found missed a different focus. I don't know, at the same time, I think in those cases, it would be interesting to have some genomic analysis to see if it's actually the same isolate or not, but we just don't do that. But yeah, that's been my brief reading and experience about that.
Thank you.
Thank you.